Dear colleagues, thank you for the opportunity to speak today. I will be discussing blood transfusion in the intensive care unit. Thank you. For whom, when, and why. In this presentation, I provide of the key aspects of patient blood management program. This is the multidisciplinary approach designed to improve our patient outcomes. It is focuses to identifying and treat anemia, minimizing blood loss, and have to provide outcomes for the patient. Patient blood management built on the three fundamental pillars: optimizing hematopoiesis, improving blood cell mass, minimizing blood loss and bleeding, and optimizing tolerance of anemia. Anemia is defined by World Health Organization as a condition in which the number of the red blood cell or the concentration of the hemoglobin is insufficient to meet the body's physiologic needs. Anemia is a common comorbidity in the intensive care patient, affecting approximately almost 75% of the patient at the discharge. The incidence of anemia is associated with a high level of transfusion requirements, increased transfusion associated complication, prolonged hospital stay, and increased mortality rate. It is multifactorial and triggered by underlying disease, comorbidities, and iatrogenic factors. Today I will be discussing how we can improve outcomes for our patient, effective blood transfusion management. As Lord Kelvin said, if you cannot measure it, you cannot improve it. The main point is the accurate measurement is very important in the ICU, but what we can measure and how can it improve our decision about the blood transfusion. The primary goal in the ICU to ensure hemodynamic balance, hemodynamic stability, and equilibrium between oxygen delivery and consumption. When this balance is disrupted, we can find several clinically and laboratory finds. Clinically, it may show us arrhythmia, hypotension, dyspnea, new onset regional valve motion abnormality. The laboratory parameters may show low hemoglobin level, iron, folic acid deficiency, and abnormal coagulation parameters. As I mentioned before, the hemodynamic stability requires, we see this picture a little bit earlier, balance between oxygen delivery and consumption. Maintaining hemodynamic stability, we can monitoring laboratory and clinical parameters, but we should measure some bedside parameters to improve our patient outcomes. Those bedside parameters could be sign of acidosis, elevated arterial lactate, decreased carbon dioxide diffusion coefficient, increased arteriovenous oxygen difference, or decreased central venous oxygen saturation. As you can see, the hemoglobin concentration is very important in both oxygen delivery and consumption equations. While the oxygen consumption still remains stable as the oxygen delivery decreases, but this is up to certain threshold. When the oxygen, why the oxygen consumption is going higher. Sorry, it's missed. So during the oxygen delivery is going down. We can reach this the one critical point when the oxygen consumption and oxygen delivery is not good. It's not enough for the tissue. It's leading to tissue hypoxia. When the patient anemic, critical ill, or both, they can reach that critical point and leading to tissue hypoxia. Sorry, I forgot to go down. In our main goal in the ICU, to keep this balance, reduction of iatrogenic blood loss, reducing iatrogenic blood loss, treating anemia, and managing coagulation, managing coagulopathy. One of the main contributors to iatrogenic blood loss is the mainly phlebotomy, frequent phlebotomy in the ICU. Several studies suggest this blood loss range can be between 10 to 770 milliliter per day in the ICU. So what we can do, how we can reduce this blood loss? One possibility to use a blood collecting tube which requires less values, or use a specific diagnostic test like a point curve of diagnostic test which require less amount of the blood. Additionally, I would like to mention how important to measure the iron deficiency in the ICU. Almost 40% of our patients deal with these iron metabolic disorders upon admission. Incidence of anemia can be elevated further by fluid resuscitation, drug-induced coagulopathy, or insufficient enteral feeding, insufficient nutrition. All of those factors we can reduce by very careful management. What is the research about the transfusion right now? Current literature supports the restrictive blood transfusion with hemoglobin threshold of 70 grams per deciliter. But some of this condition, it may be too low, or that's why they suggest a little bit higher hemoglobin threshold for special population. So what we can do? Ultimately, we can use we should individualize transfusion threshold and use patient-centered transfusion strategy for those critical ill, hemodynamically unstable patients. It is include optimized tolerance of anemia by monitoring clinical signs, treat anemia, and use restrictive evidence-based transfusion strategy for hemodynamically stable patients. But for hemodynamically unstable patients, individualize hemoglobin threshold by guiding some bedside parameters, bedside signs, which help us to detect imbalance between the oxygen delivery and consumption. It is recommended to give 1 unit of the red blood cell at a time. Of course, we have to follow each transfusion, close monitoring, and analyze those dates that I mentioned before. We can decide if the further transfusion is necessary or not. The other hand, we should optimizing iron deficiency, coagulopathic coagulation disorders, malnutrition, and minimizing iatrogenic blood loss to minimize incidence of anemia and decreases incidence of transfusion in the ICU. Backcutting management is a very hot topic and a very complex topic. So I would like just mention two things about that. First, with some specific diagnostic tests, we should allow to identify and replace some specific missing cutting factors. And additionally, normalizing body temperature, pH, and ionized calcium levels, we can support the hemostasis. For any successful blood management program, it is important standardized algorithms for definition and treatment of the blood transfusion. Continuous education for both healthcare staff and patients ensure to adherence this program, and ultimately, additionally, we can with the ongoing collection, analysis of data, and periodic revision of the therapeutic protocols, we can improve our blood patient management. This is what we do in our department. We use this transfusion calculator to standardize our transfusion protocols and to individualize our patients' transfusion threshold, individualize our transfusion strategy. For the take-home messages, in the hemodynamically stable patient, we should use, it is recommended to use evidence-based transfusion strategy with hemoglobin level for 700 grams per liter. But for the hemodynamically unstable patient, we recommended use individualized transfusion strategy guiding by some specific bedside parameters. And thank you for your attention. I hope I was quick.